Hello, I'm Dr. Theodoros GRIVAS, orthopedic and spinal surgeon, and I'm going to speak on school screening for scoliosis, a school screening program in Greece, our 25 years journey, what we have learned, succeeded, and published. We have nothing to disclose.
School scoliosis screening usually and particularly serves the juvenile idiopathic scoliosis and adolescent idiopathic scoliosis without excluding possible cases of known etiology.
The history of our SS program started in 1996. Finally, our SSS program was legislated by the state of Hellenic democracy, Greece.
The original and main aim of scoliosis school screening is to identify most or all of the individuals with unrecognized idiopathic scoliosis at an early stage when a less invasive treatment is more effective. In other words, is prevention. Beyond its original aim, the SSS provides the opportunity for a collection of various cross-sectional data, comparison of normals to asymmetric, services the epidemiology and natural history of AIS, is a human evidence-based clinical research tool for AIS scoliogeny based on the study of humans and not animals and established on the concept that the morphology expresses, reflects, and deciphers, decodes the physiology and pathology. At our SSS program were examined children 6 to 18 years old, thus we had a great opportunity to collect data from a wide age range of the examined children and adolescents. The organization of the SSS program consists of the application of the hospital administration applied to the Greek Ministry of Education, the positive recommendation of the Ministry of Education with a circular sent to elementary and high schools, and the contact of the school principal and supply with the educational material about our SSS, and the consent letter for the parents who are asked to sign for their children to get examined, and finally the invitation referral letter for re-examination at the hospital when needed. The examination team consists of orthopedic doctors, physiatrists, general medical doctors, health visitors, nurses, and physiotherapists. For the examination of the truncal asymmetry during the Adams tests, we are using the scoliometers. The Pruitt scoliometer reliability study is satisfactory and can be found in this published paper. The truncal asymmetry is assessed, also the height and weight. The scoliometry is conducted in standing forward bending and sitting forward bending position in boys and girls in mid-thoracic, thoracolumbar, and lumbar region. In case of lumbar region scoliometer asymmetry, we assess the length of the legs to diagnose a possible leg length inequality. In case of asymmetry, our recommendations for re-examination are the following. In children less than 13 years, if ATI is more than 6 degrees, and in children more than 14 years, if ATI is more than 5 degrees.
The direct examination cost for each child for the above studied period was calculated to be €2.04.
Our evidence-based recommendations for improved implementation of SSS program are the following. The financial information for screening, which is available to decision makers, should be based on the studies of the direct cost of the program. The direct cost of a screening program can be reduced to a minimum if it is well organized and carried out on a voluntary basis. During the first 13 years of implementation of our SSS program in Thriasio Hospital, we also did footprinting, and I'm going to explain the reason we did it later on in this presentation.
As far as the secretarial work, we have the following policy. A pair of team examiners is assigned for each measurement, One examiner does the measurement and the other records the results in the protocol form. This is a time-saving policy.
Our examination protocol includes information of the examined children and also of their parents.
The implementation of SSS program is inextricably bonded to non-operative treatment of idiopathic scoliosis, for which we are going to speak next.
We developed and validated the BRACE questionnaire to measure the quality of life of our BRACE-treated scoliotics. This questionnaire is translated in English and it has been translated and validated into Polish, Dutch, French, Chinese, Italian, Korean, Persian, Turkish, Swedish and Russian language. In 2011, SRS presidential line mandated 8 international expert SRS members to explore scoliosis screening from a multinational perspective. And this published paper in the Open Access Journal Scoliosis details all the conclusions of this Scoliosis Research Society International Task Force on Scoliosis Screening.
The SRS International Task Force on Scoliosis Screening finally concluded that SSS program is recommended.
The implications of the BRACE study presented in Lyon at 48th SRS meeting pointed out that early detection is important and that screening policies must be reconsidered.
Several studies describe the positive impact of the SSS programs and of the high standard non-operative treatment on reducing the frequency of surgical AIS treatment. Additionally, studies in Canada and Norway describe the negative impact of discontinuation of SSS programs. The fact is that these reported consequences of discontinuation of the SSS programs were widely expected, and the triumph of epidemiology over early diagnosis was in reality a disaster. Prevention must be a standard policy in civilized societies. As I stated earlier, the school scoliosis screening programs are also clinical research tools providing a gold information about scoliosis, and I'm not going to read all these titles, but I'm going to take you through to save some time. We documented the incidence of idiopathic scoliosis in Greece, which is 2.1, taking in consideration that the co-bangle is more than 10 degrees. Analysis of our screening program collected data yielded the somatometric parameters, enabling us to do comparison of body weight and height between normal and scoliotic children and study the back trunk morphology of these children. This study showed that in our Mediterranean population, the somatometric parameters of height and weight in AIS children, regardless of care type and site, are not statistically different from their non-scoliotic counterparts. Analyzing this data, we were able to study the trunk asymmetry in normal children and adolescents and juveniles as well.
We studied the role of the brain in trunk asymmetry and AIS pathogenesis. Studying the trunk asymmetry and handedness in school children, we found that there is significant correlation of mild mid-thoracic asymmetry with the dominant brain hemisphere in terms of handedness in children who are entitled at risk of developing scoliosis.
The documentation of menarche in screened girls show us that in premenarcheal girls, if they have scoliosis, they are presented with left curves and left thoracic, and if these girls are postmenarcheal, they have right thoracic curves, and this is interesting finding. Yet, there was no statistically significant difference of the age at menarche between scoliotic and non-scoliotic girls. 20 years later, these findings were confirmed in a study in other Balkan countries and presented in the recent SOSORT San Sebastian meeting.
We studied the age at menarche and the prevalence of idiopathic scoliosis in various publications, and we show that there is a lot of differences. Therefore, we documented the latitude of each publication.
And we plotted the prevalence of scoliosis and age at menarche by latitude, and we found similarity in the curves of these two analyses.
Melatonin in girls has a positive effect on their sexual maturation when its production is decreasing and consequently stops inhibiting the luteinizing hormone at ovulation. In northern latitude countries, this sexual maturation happens later due to poor light environmental conditions, resulting in increased AIS prevalence. This hypothesis implicates increased melatonin levels in the pathogenesis of idiopathic scoliosis. The phenomenon of the increased AIS prevalence in the northern globe is also happening as it was found in this study in the south hemisphere.
The results of the previous project was recently published in Andes Pediatrica.
Screening girls with visual deficiency, we found that their age at menarche was late compared with normal peers, and they had higher prevalence of scoliosis.
Screening a wide range of children ages and analyzing their data, it resulted in some very exciting findings. For the first time, it was found that younger children with truncal asymmetry may have a straight spine with no vertebral rotation despite the presence of a thoracic hump. Also, the thoracic edge develops asymmetrically first. We suggested the double rib contour sign and the rib index for the assessment of the thoracic edge deformity in the transverse plane. The scoliotic spine first deforms at the level of the intervertebral discs due to the increased plasticity of the IVD and not the vertebra. The lateral spinal profile of mild scoliosis is rather a compensatory mechanism.
The complete study of double rib contour sign and rib index was published in Scoliosis Journal, which is an open access journal. Practically, the rib index is assessing the rib cage deformity in the transverse plane. The application of rib index in the clinical practice is useful for documentation of the rib cage deformity initially before any treatment, after PSSs, after bracing, and post and preoperative. Studying the segmental rib index from T1 to T12, it was found that females present a pattern of numerous thoracic vertebral levels in thoracic curves, while male unexpectedly present a pattern in numerous vertebral levels in thoracolumbar curves.
As I mentioned earlier, we discovered that the scoliotic spine first deforms at the level of the intervertebral disc IVD rather than the vertebra, and 3 years later these findings were confirmed by Will et al., the team of my friend Ian Stokes. In Lyon in 2009, we presented our concept of a comprehensive model of idiopathic scoliosis progression based on the pathobiomechanics of the deforming three-joint complex, the disc and the facets. This seems to happen because the wedged scoliotic IVD during the night imbibes water and during the day expels it because it is loaded, and it acts as an accordion. Therefore, asymmetrically is pressing the end plates, and consequently there is asymmetrical spinal growth in bodies and facets according to Powell's law and Houghton principle. The full concept can be studied in our recent publication, The Diurnal Variation Accordion-like Phenomenon, a wedged invertible disc, a progression factor in idiopathic scoliosis, in this open access journal, Annals of Pediatric and Child Health.
Studying the effect of growth on spinal ribcage deformity, it was found that approximately 30% of younger SSS girl effort were found to have either a straight spine or a spinal curve co-angle less than 10 degrees. In this age group, the correlation between clinical deformity and radiographic measurement is not statistically significant, while in older SSS-referred girls it is.
Now, our evidence-based policy recommendation on SSS implementation is that all younger SSS individuals who are identified using a scoliometer with a surface deformity but without a radiologically confirmed scoliotic curve are at risk for AIS development, and they need to be followed, not discharged from the clinics. Looking at the lateral spinal profile of adolescent idiopathic scoliosis patients with thoracic curves, thoracolumbar curves, lumbar curves in children with straight spines and in children with a curve with a co-angle less than 10 degrees, it was found that the lateral spinal profile was not significantly different among all these groups.
The previous study provides evidence that in mild scoliosis, the thoracic hypokyphosis by alleviating axial rotation is rather a compensatory mechanism than an etiological factor for AIS scoliogeny. The results of the previous study was additionally verified by this presented publication.
Looking at the thorax of our AIS referrals from school screening, it was realized that in scoliotic children with mild curves, these children have an underdeveloped thoracic edge compared to non-scoliotic counterparts.
We had the opportunity to study the idiopathic and normal lateral lumbar curves to see the muscle effects interpreted by 12 rib length asymmetry with pathomechanic implications for lumbar idiopathic scoliosis, and we suggest that one mechanism leading to relatively increased length of the right 12th rib is mechanotransduction in accordance with Wolff's and Powell's laws. Studying the footprints, we found that the significant correlation between idiopathic scoliosis and cavus foot, as it has been elsewhere reported, was not verified.
Now let's have a look in school scoliosis screening and epigenetics. Parental age at birth is implicated as a possible epigenetic mechanism in trunk asymmetry of a child, as we found in our studies. We found that maternal age at birth does indicate the epigenotypic expression of truncal asymmetry of a child, and it seems that males are more affected by this factor, but unexpectedly in our study by younger and not older mothers as reported for AIS in the literature. Studying referrals with leg-leg inequality and implementing the surface topography, it was found that leg length inequality was not statistically significant correlated with scoliosis angle and the scoliometer reading at the lumbar level. Very interesting finding, needs more study.
Additionally, using the scoliometer and the surface topography apparatus to check if back trunk asymmetry changes in children and adolescents in the forward flexion and standing erect position, we found that this asymmetry in children and adolescents differs in the forward bending flexion and standing erect position.
Setting up a screening program, the examiners must be familiarized with certain issues. How to obtain permission from the administration of the hospital and the Ministry of Education to perform the screen, how the examiner groups are organized, the instruments forms on which the team must be appropriately trained, training in behavioral issues of the children and adolescent age groups, the methods of communicating with the school administration and management of the materials. Additionally, the decision-making for the time and the screening frequency and performance, management of the data collection, its processing and analysis, how children are monitored, including referral to the outpatient clinic for reassessment and the onset of early non-operative treatment, and to increase the community's awareness and insight into scoliosis. It is very important the foundation of a special center for the training of school screening examiners in each country.
The trainees must implement the SSS program at schools, attend the scoliosis clinic of the hospital, and the educational program of the center.
Now, the pendulum swings back to scoliosis screening. Finally, answering to the question to screen or not to screen, SOSORT and SRS answer yes, we must screen, and it is obvious that prevention is a medical offer to the society and to the national economy. And we have always to bear in mind that prevention is better than treating. Thank you very much for your attention. Ευχαριστώ πολύ για την προσοχή σας.